Good morning, friend. Myself, Dr. Vipul Gujar. I am the professor and head of Department of Surgery in SBKS Medical College, Vadodara, and I am the private practicing surgeon in Vadodara. Today is the 13th Jan, and it's a kite festival by from tomorrow in Gujarat. I am welcoming you, all of you, my colleague and friends, to come and enjoy our kite festival in Gujarat. Okay. Today I'm further going ahead with the most awaited topic of laser surgery in a piles. Okay. I think everyone is knowing now the laser is becoming boom for the pile surgeries, and everyone, many are doing with the pile surgeries, but there are lots of different opinion about what first, how to enter in the pile mass. That means one group is saying that from the lateral entry, and second group saying that from the indirectly inside the pile mass. Second point, the energy, how much energy we should give, and third thing, about which fiber can be more efficient for the pile surgery. And fourth thing, what about the mucosal prolapse, which is mainly associated with the pile mass? Now, first, there are the two type of group is there. One group is suggested that we should go with the bare fiber and bare fiber with the lateral entry. And second group is, first we will discuss about the lateral entry. This group is saying that we should spray 30% of our energy from anal region over the pile pedicle mucosa. Then we should enter from the intersphincteric or just lateral to intersphincteric groove directly towards the pils pedicle, and gives a rest 40 percentage of energy, and rest 60%, 30%, 40% in the directly pile mass. Okay, so lateral entry. This lateral entry is very good, in my opinion, about the less chances of mucosal and a burn, as well as chances of bleeding from the pile mass. But in my opinion, the spraying of energy over the piles pedicle from the anal side, that means intra-anal, it is somewhat not accepted, because I thought the collaterals are the submucosally and deeper to that submucosally, and we have to keep the tip 5 millimeter above from the mucosa to prevent the burns. So I don't think because of just spraying the laser from the intraanal, it will affect any vascularity which is remained the submucosal level. It will give only the burns. So I don't think it should be done. On my opinion, my personal opinion, you can use directly pile mass, and you can divide your required energy in two phase. One is the pedicle, and second is the directly pile mass from the lateral energy. But from the lateral side, only bare fiber and curved handpiece must be used. There is conical fiber cannot puncture directly in such a thick skin and subcutaneous tissue or muscle itself. So lateral entry, yes, you can do, and from my side, I am doing the maximum with the lateral entry. But from the 11 o'clock piles, this lateral entry or through the sphincter mass, it is somewhat difficult. So many times I have to go directly inside the pile mass only. Now the what is the second group of opinion? The second group is that with the mucocutaneous junction, they enter the fiber, goes towards the pedicles, they gives the energy in a single shot. In this case, you can use a conical fiber, or you can use a bare fiber itself only. Okay, this group, Yes, direct pile mass entry, regression of pile mass is very good, but simultaneously we are getting, or I am getting, somewhat a hematoma and a bleeding from that pile mass in compared to lateral entry, as well as mucosal burn and delayed the hemorrhage is quite common in such a procedure also. So my first choice is a lateral entry in 3 or 7 o'clock, and second choice is the direct pile mass entry. Now, second point is the which fiber is useful. Okay, my particularly as well as recommended fiber is the conical fiber. Conical fiber has a efficacy to protect the direct laser concentration at one point, and it sprays energy in 270 direction. So we do need to rotate the fibers as much in compared to bare fiber. Okay, so conical fiber, it can be considered as a cold fiber, in which we have to use a straight hand piece, or many people are using a direct fiber. They give the energy at the mucocutaneous, they make some artificial hole and push the tip inside the pile mass. uh, and then they give the energy. uh, Sometimes the peoples are also using as a bare fiber. After busting tip of conical fiber, many surgeons are not purchasing the conical fiber further, but they use as a bare fiber as a pile surgery. Yes, we can do, but not in a similar manner, because bare fiber working in a 180 direction only. They are concentrating energy at one point. So ideally, if you are using a bare fiber, then the tip must be rotated left and right, as well as front and back side, so it will cover the whole pile mass in a adequately, so the regression of pile mass is possible. So which fiber? First fiber, if you are using, and the preferred fiber is the conical fiber. If you are not doing, if you are doing with the bare fiber, it is no harm. Many people and most of surgeons are doing with the same manners, but with the some tricks. You have to adjust your energy as well as to entry side to use a bare fiber. Okay, how much energy we should give for a pile mass? So it is very much a larger discussion point. I have given a separate video about the energy source per pile mass. It is not recommendation that this piles require this energy only. But the most of people are doing the 150 to 200 joule per pile mass. Okay, but I am very much against of making such a boundary about the energy. I think the piles must be coagulated adequately. This much energy must be delivered. That means, how can clinically we judge if we, after this entering of fiber, if you feel your pile mass is becomes like a somewhat near to firm, then it is a ideal situation, because this firmness becomes a thrombus and lateral lysis and fibrosis of pile mass will be possible. So the energy may be vary from 100 to 300 according to size of pile mass and chronicity of the pile mass. So energy, how much? There is a someone separate video in my YouTube. You can go through in it. Okay, and now the laser machine in a pile surgery. How much laser machine has to keep? That means a watt of a laser machine. See, in most of companies, they are pre-settled criteria is available. That is grade one, grade two, grade three. If you push that button, the all the this criteria is come in the preset level on your screen. My recommendation, if is 6 watt, is very good energy watt machine that prevents less burning mucosa, as well as less hematoma and less chances of ischemia, local ischemia of the mucosa. Okay, what about if there is a mucosal prolapse or prolapsing piles? See, in a second or first degree bleeding piles, you can directly go with the direct pile mass entry. But later on, this mucosal prolapse is a headache for you. How to deal with this? So I advocate a mucopexy, that is known as a kissing knot, in which we are taking one long suture and 3 centimeter above the piles pedicle, and second suture over the pedicle. Then later I am tying this both the suture itself, so it becomes a kissing knot, and that will give the satisfaction of a prolapse also. Even circumferential piles also, multiple kissing knot is beneficial if you want to do with the laser surgery. So this about all about the procedure, how to do the piles surgery with the laser. Okay, and now about the complication of laser pile surgery. In my practice, I am saying about my practice only today, and that most common problem is the after the 8 to 10 days of pile surgery, I'm getting a edematous anal verge. Second thing, delayed. That is a very common in my practice. That is about 10 to 15 percentage of this case are coming back with the pain and swelling, and this it will be subside later on with the conservative management. And this happens mostly when I cut the skin tag or skin mucosa. This happens more if I am dealing with the directly pile mass without any cutting that about the skin tag and anything. Then this type of later skin edematous is not occurring. Second problem is the delayed bleeding. Yes, it is possible because of this when there is a good larger amount of energy is given what is required, later the mucosa becomes a slough out, and this hematoma becomes a as a bleeding present with the bleeding, and mostly it will stop itself in within the 48 hours. If it is not stop and continuous bleeding is there, then patients may require examination under general anesthesia, and we may need some bipolarization of that bleeding point also. This happen in my practice about 2 to 3 percentage definitely. At this stage also I'm getting such a problem. Okay, now the third problem is the pain. Yes, this pile surgery with the laser is always associated with the mild burning pain. It can compared with the hemorrhoidectomy also. So it is not a totally 100% painless surgery. Okay, what about the fourth problem is the infection. After the this all the criteria of anal wash, as well as pre bowl preparation, antibiotic, as well as ETO of your hand piece and hand fiber, this laser fiber, I am getting less cases of infection itself. Only hardly 1% may be there is the infection of so pile mass after the surgery. As well as many people are asking about the fistula formation. If we are going with the laterally. No, in initial practice, I got one or two case in 50 of 30 cases. Out of that, I got this one type of small fistula, but I do not require a long fistulectomy from this lateral entry of fibers. So don't worry about the fistula formation. If your technique is good, there won't be a problem of fistula formation in a lateral pile surgery. Okay, now one of the most the questions of the person who is not doing the laser surgery, they will definitely ask what is the piles regression on follow up. If you are adequate surgery about the energy delivery, that means you have given adequate energy, then definitely on follow up of approximately 1.5 month, there will be a flat mucosa is possible, and the all pile mass will regress 100%. With the kissing knot, the mucosal part also improved definitely. So it is beneficial. Or this mucosal prolapse, you can add like a 30% mucosal problem is solved in this problem with the laser and Mucopex. Okay. If there is a larger pile mass, if it is a larger pile mass and patient wants on the laser surgery, then injection hyalinize is injected in the pile mass and wait for the regression, gives the massage, do the mucopexy, and then enter the laser fiber. It gives a good result. This is the technique when you will get a larger pile mass which require excision, but you don't, or the patient don't want to go for the excision, then you can utilize such a procedure, injection hyalinize in the intrapile mass. Okay. Okay. What about the post-operative care? These patients are done in my practice under spinal anesthesia. I am using Rupivacaine for the spinal anesthesia. That includes they don't require that much muscle relaxation. I'm putting the ice pack every time before and after application of laser surgery. I prefer the mucopexy every time. If it is a very small accessory piles, then I am not doing that thing. And after the completion of surgery, I'll definitely put diclofenac, xylocaine, as well as the betadine suppository intrarenal, as well as I am applying a ab gel inside that, because it absorbs excessive fluids, as well as it improves the prevents the somewhat bleeding tendency of that puncture site also. And I am giving the definitely analgesic, I mean antibiotic, when the patient is remain admitted for the 24 to 36 hours. After the discharge, I am prescribing analgesic, antibiotic, as well as stool softener also. I am doing examination in OPD every 5 days. I am doing first on the PR examination on 5th or 7th day. I am doing the second PR examination on 14th to 15th day of first surgery surgery, as well as I am doing the proctoscopy examination after 1.5 months to see my result. So that's all about my pile surgery with the laser. If you want to say that it is truly said about my practice, no, my preferred practice is a hybrid laser surgery in compared to using a alone laser surgery. If there is a no cost is a problem to the patient, I will go with the hybrid surgery. And that's all. Thanking you very much. If you have a problem, please send me the message I'll try to solve your problem. This is thoroughly about my practice and my experience about the laser. Your data or the paper may give some different view, but we can discuss according to it. There is a no long-term data is published for the laser surgery.